Chapter 42, Shock, Sepsis, and Multiple Organ Dysfunction Syndrome. What is shock? Shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. This imbalance between the supply of and demand for oxygen and nutrients, and it comes in many different forms: cardiogenic, hypovolemic, distributive, or obstructive. Starting with cardiogenic shock, it can be classified as either systolic or diastolic dysfunction. In the case of systolic dysfunction, it's the heart's inability to pump that blood forward, most commonly caused by a myocardial infarction. There's a decreased filling of the heart will result in that decreased stroke volume and low cardiac output and a cardiac index. While a myocardial infarction is the most common, there are other causes such as cardiomyopathies, blunt cardiac injuries, severe systemic or pulmonary hypertension, cardiac tamponade, or myocardial depression from metabolic problems. Below is figure 42.2 from the text, and whether the first event is a myocardial dysfunction, a structural problem such as valvular disorders or ventricular septal rupture, or dysrhythmias, the physiologic responses are similar. The patient experiences impaired tissue perfusion and cellular metabolism due to this lack of cardiac output and cardiogenic shock. Early manifestations include tachycardia, hypotension, narrowed pulse pressure, increased systemic vascular resistance, and increased myocardial O2 consumption. During the physical assessment, you also might notice tachypnea, pulmonary congestion, a pallor and cool, clammy skin, which is really a hallmark sign of shock, decreased capillary refill, anxiety, confusion, agitation. This increased pulmonary artery wedge pressure, stroke volume variation and pulmonary vascular resistance, and a decreased renal perfusion and urinary output. Whenever you see cool, clammy skin on NCLEX or ATI, that is that hallmark sign that they're really cueing you in for shock. On the other hand would be hypovolemic shock. In the case of absolute hypovolemia, this is loss of intravascular fluid volume, such as hemorrhage, a GI loss with vomiting and diarrhea, extreme fistula drainage, diabetes insipidus, or other forms of diuresis. Not to be confused with relative hypovolemia, which results when the fluid volume moves out of the vascular space into the extravascular space, and is termed third spacing. Next we have figure 42.3 from the textbook, the pathophysiology of hypovolemic shock. And as you can see, with both relative and absolute hypovolemia, it begins with a decreasing circulating volume, which results in decreased venous return, which in turn results in a decreased stroke volume, decreased cardiac output, and decreased cellular oxygen supply. The response to this acute volume loss depends on the extent of the injury, the patient's age, and their general state of health. The patient may compensate for up to 15% loss, though a loss of 15 to 30 results in a sympathetic nervous system mediated response. The early signs of hypovolemic shock include anxiety, followed by tachypnea, an increase in heart rate, cardiac output, and respiratory rate and depth, a decrease in stroke volume, and if the loss is greater than 30%, the blood volume needs to be replaced. Next, we'll discuss neurogenic shock, and this is a hemodynamic phenomenon. It can occur within 30 minutes of a spinal cord injury at the fifth thoracic vertebrae or above, and can also last up to 6 weeks. It can also occur in response to any spinal cord injury or spinal anesthesia, and this results in massive vasodilation, leading to pooling of blood in the vessels, tissue hypoperfusion, and ultimately impaired cellular metabolism. In the case of neurogenic shock from figure 42.4 in your text, we have that disruption of the sympathetic nervous system that results in a loss of sympathetic tone, the venous and arterial vasodilation, which results in a decrease in the blood pressure, decrease in venous return, decrease in stroke volume, cardiac output, and again that decreased cellular oxygen supply. The manifestations of neurogenic shock include hypotension and bradycardia, as well as an inability to regulate the body temperature, resulting in heat loss, dry skin, and again that poikilothermia, or taking on the temperature of the environment. In the case of anaphylactic shock, this is an acute, life-threatening hypersensitivity, allergic reaction that results in, again, that massive vasodilation, the release of vasoactive mediators, an increase in capillary permeability, and fluid leaks into that interstitial space. Other manifestations of anaphylactic shock include anxiety, confusion, dizziness, a sense of impending doom, chest pain, and incontinence. Other manifestations of anaphylactic shock include those signs of anaphylaxis, such as swelling of the lips and tongue, angioedema, wheezing, stridor due to that laryngeal edema, flushing, pruritus, urticaria, and respiratory distress and circulatory failure. Next would be septic shock, and this is a result of, just as it sounds, sepsis, which is a systemic inflammatory response to a documented or suspected infection. In the case of severe sepsis, this is sepsis complicated by organ dysfunction. The presence of sepsis with hypotension despite fluid resuscitation, and the presence of inadequate tissue perfusion resulting in hypoxia. The three major pathophysiologic effects are vasodilation, maldistribution of blood flow, myocardial dysfunction, and decreased ejection fraction and ventricular dilation. Next would be figure 42.5 from the textbook. As you can see, septic shock has three major pathophysiologic effects: vasodilation, maldistribution of blood flow, and myocardial depression. The manifestations of septic shock again include that increased coagulation and inflammation, as well as a decreased fibrinolysis, meaning the formation of microthombri, which could eventually obstruct the microvasculature. In the case of tachypnea and hyperventilation, this results in respiratory alkalosis, and that respiratory failure develops in 85% of patients. We may also see altered neurologic status, GI dysfunction, GI bleeding, and paralytic ileus. Obstructive shock. This develops when physical obstruction to blood flow occurs with decreased cardiac output, and is caused by restrictive diastolic filling of the right ventricle from compression. Also, abdominal compartment syndrome. Abdominal pressure compresses the inferior vena cava. In this case, the patient will have decreased cardiac output, increased afterload, and a variable left ventricular filling pressure. In figure 42.6 in the text, it follows a very similar pattern to our other forms of shock, in which case there is a structural compression that is stopping the outflow, decreasing venous return, decreasing stroke volume, decreased cardiac output, and decreased cellular oxygen supply. In our first case study, AM, a 26-year-old man, arrives via paramedics to the ED with multiple gunshot wounds to the abdomen. He is unresponsive with a blood pressure of 58/30 and a heart rate of 146. What type of shock is he experiencing? With this much bleeding, hypovolemic. And AM's heart rate continues to increase and is now 188, blood pressure 50/32, and he has no urine output since admission. As you assess the patient, his bowel sounds are hypoactive and his skin is cool and clammy. Which stage of shock is AM in? Currently, he's in the compensatory stage, as his body is trying to compensate for that blood loss. And what compensatory mechanisms are working to maintain that cardiac output? We'll see that here on the next slide, but that tachycardia, his heart is trying to pump more blood that is not there. Shock is categorized into four overlapping stages: initial, compensatory, progressive, and refractory. In the initial stage of shock, it's usually not clinically apparent. The metabolism changes at a cellular level from aerobic to anaerobic. When this happens, lactic acid begins to build up and must be removed by the liver. This process requires O2 that's unfortunately unavailable due to the decreased tissue perfusion. Next would be the compensatory stage. In this case, the patient has their compensatory mechanisms kicking in to try to pick up the slack, whether they're neural, hormonal, or biochemical. In this case, the body is attempting to overcome the consequences of anaerobic metabolism, get that pressure back up where it needs to be, and maintain homeostasis. In the compensatory stage, baroreceptors in the carotid and aortic bodies activate the sympathetic nervous system in response to decreased blood pressure. Vasoconstriction, while blood to vital organs, is maintained within the heart and the brain. Within this compensatory stage, the sympathetic nervous system stimulates to increase myocardial O2 demands. Shunting blood from the lungs increases physiologic dead space and also results in a decreased arterial O2 levels and an increase in the rate and depth of respirations. Other compensatory mechanisms may be impaired GI motility, slowed peristalsis, and a risk for a paralytic ileus. Also, that cool, clammy skin that is a hallmark. Whenever you see cool, clammy skin on ATI or NCLEX, they're usually cueing you into shock. And this is present in everything except septic patient, who is usually warm and flushed. Finally, the decreased blood to the kidneys activates the renin-angiotensin system, which results in vasoconstriction, increased venous return to the heart, stimulated the release of aldosterone, and increased sodium reabsorption stimulates the antidiuretic hormone. The body can compensate for changes in tissue perfusion. If the cause of the shock is corrected, the patient can recover with little or no residual effects. Unfortunately, if the cause of the shock is not corrected, the patient can continue to progress through these stages. If the body was unable to compensate, we would then lead into a progressive stage. And this begins when the compensatory mechanisms fail. The patient's moved to the ICU for advanced monitoring and treatment. It has distinguishing features of decreased cellular perfusion and altered capillary permeability, leakage of protein into the interstitial space, and the increase of systemic interstitial edema. Cardiac output begins to decrease, resulting in a decrease in the blood pressure. You may also see anasarca, or a diffuse profound edema, and this is the result of the fluid leakage effects around these solid organs and peripheral tissues. It also causes decreases in blood flow to pulmonary capillaries. Sustained hypoperfusion can lead to a weak peripheral pulses and eventually ischemia of the distal extremities. Within this stage, myocardial dysfunction can result in dysrhythmias, myocardial ischemia, possible myocardial infarction, with an end result of complete deterioration of the cardiovascular system. The movement of fluid from the pulmonary vasculature to the interstitium results in pulmonary edema, bronchoconstriction, and a decreased functional residual capacity. As the fluid moves into the alveoli, we may also see edema, a decrease in surfactant, a worsening VQ mismatch, a tachypnea, crackles, and an increased work of breathing. Within the GI system, the mucosal barrier begins to become ischemic, leading to ulcers, GI bleeding, risk of migration of bacteria, and a decreased ability to absorb nutrients. Hypoperfusion eventually leads to renal tubular ischemia, which may result in acute kidney injury, worsened by nephrotoxic drugs, a decreased urine output, elevated BUN and creatinine, and metabolic acidosis. As the liver fails to metabolize drugs and waste, we begin to see jaundice, elevated liver enzymes, a loss of immune function, and possibly even disseminated intravascular coagulation and significant bleeding. And finally, the patient would enter the refractory stage. In this case, we would see an exacerbation of anaerobic metabolism, the accumulation of lactic acid and waste products, increased capillary permeability, profound hypotension and hypoxemia, a worsening of the tachycardia, the failure of one organ system, and an unlikely recovery. While there's no single study to determine shock, we want to look at elevated lactate, a base deficit, combined with a 12-lead ECG, a chest x-ray, continuous pulse oximetry, close hemodynamic monitoring, and that thorough history and physical examination. Continuing with our case study, AM receives 3 units of type O packed red blood cells for profuse blood loss. An ECG and chest x-ray are done, and he's going to the OR for removal of bullets and repair of injuries. What other interventions are necessary at this stage to prevent progressive shock? Successful management includes identification of patients at risk for developing shock, an integration of the patient's history, physical examination, and clinical findings to establish a diagnosis, interventions to control or eliminate the cause of decreased perfusion, protection of target and distal organs from dysfunction, and finally the provision of multi-system supportive care. Other general management strategies include ensuring the patient is responsive, ensuring a patent airway, and maximizing oxygen delivery. For oxygen and ventilation, we want to increase the supply, optimize the cardiac output with fluid replacement or drugs, increase hemoglobin by transfusion, increase arterial oxygen with supplemental oxygen and mechanical ventilation, and plan care to avoid disrupting the O2 supply and demand. The cornerstone of therapy for septic, hypovolemic, and anaphylactic shock is volume expansion. In this case, we'd place 1 or 2 large bore IV catheters, maybe even an intraosseous access device or central venous catheter if we were having trouble gaining access, isotonic crystalloids such as normal saline or lactated ringers, and even packed red blood cells for the volume loss due to bleeding. Fluid responsiveness is determined by the clinical assessment, such as vital signs, cerebral and abdominal perfusion pressures, capillary refill, the patient's neurologic status, skin temperature, and urine output. Other interventions to monitor fluid response include passive leg raises challenge. Though this large volume transfer does come with 2 major complications, hypothermia and coagulopathy. This persistent hypotension after adequate fluids, a vasopressor may be added. Also, fluid resuscitation, such as warm crystalloid and colloid solutions, help to replace the clotting factors and assess carefully for the hypocalcemia and disseminated intravascular coagulation. The primary goal of drug therapy is the correction of that decreased tissue perfusion. Our first step would be vasopressor drugs, such as norepinephrine. We want to achieve and maintain a MAP greater than 65, and we want to reserve for patients unresponsive to fluid resuscitation and continuously monitor end organ perfusion. In the case of vasodilator therapy, such as nitro, this comes with a risk of a decreased afterload. We want to carefully make sure that we're maintaining a MAP greater than 65 and monitor the hemodynamic parameters very closely. Vital to decreasing the morbidity from shock is nutrition therapy. In this case, we want to start enteral nutrition within the first 24 hours. Start trophic feedings closely. Slow the drip to small amounts of enteral nutrition. In the case where parenteral nutrition is necessary, it should be only used when enteral nutrition is contraindicated. We want to weigh the patient daily and monitor the labs closely for any changes or trends. In the case of cardiogenic shock, our overall goal is to restore blood flow to the myocardium by restoring the balance between oxygen supply and demand. Also, angioplasties with stenting, emergency revascularization, and even valve replacements. Should drugs be used like nitrates, diuretics, vasodilators, and even beta blockers, we want to monitor the hemodynamics closely. Should a circulatory assist device be necessary? They could use many options, such as intra-aortic balloon pumps or a ventricular assist device, or in very, very severe cases, up to a heart transplantation. Hypovolemic shock management focuses on stopping the loss of fluid and restoring the circulating volume. Fluid resuscitation is calculated using the 3-to-1 rule, meaning 3 milliliters of isotonic crystalloid for every 1 milliliter of estimated blood loss. Continuing with our case study, AM surgery is successful in removing bullets and repairing blood vessels. The surgeon estimates he lost 3 liters of blood before surgery and 1 liter more during surgery. What fluids would be given at this point to further stabilize his volume? Also, he is intubated, has a central line catheter and an arterial line. His blood pressure is 102 over 54, a heart rate of 104, and a cerebrovascular pressure of 7. What medications may he receive? For the fluid replacement of that patient, we want to restore the intravascular volume and organ perfusion. Again, initially 30 milliliters per 1 isotonic crystalloid solution and careful hemodynamic monitoring. Also, vasopressor drugs such as epinephrine and exogenous vasopressin to replace the stores of physiologic vasopressin. In the case of septic shock, IV corticosteroids are considered for patients who cannot maintain an adequate blood pressure with vasopressor therapy despite fluid resuscitation. We want to start antibiotics within the first hour, after cultures have been obtained, of course, And other things include blood, wound exudate, urine, stool, and sputum cultures. We want to start with a broad spectrum antibiotic, and then more specific antibiotics may be ordered once the culture results come back and the organism is identified. Glucose levels should also be carefully monitored in septic shock and maintained below 180. Stress ulcer prophylaxis with proton pump inhibitors may also be indicated, along with venous thromboembolism prophylaxis, such as heparin or Lovenox. In the case of neurogenic shock, spinal cord injury and spinal stability is a priority. The treatment of this hypotension and bradycardia with vasopressors and atropine. Fluids infused cautiously, as hypotension generally is not related to fluid loss. And we want to monitor closely for hypothermia caused by that hypothalamic dysfunction. Epinephrine is the drug of choice, including diphenhydramine, histamine receptor blockers such as famotidine, and we really want to focus on maintaining a patent airway. ABCs is always priority. That nebulized bronchodilators, aerosolized epinephrine, and endotracheal intubation. For anaphylactic shock, we want to have aggressive fluid resuscitation, along with IV corticosteroids if significant hypotension persists after 1 to 2 hours of therapy. In the case of obstructive shock, the primary strategy is early recognition and treatment to relieve the obstruction, including mechanical decompression, thrombolytic therapy, radiation, debulking or removal of mass, or in the decompression of a laparotomy. And we can't stress enough, ABCs, those are always the priority over everything. Airway, breathing, circulation. AM's airway and breathing are successfully managed via mechanical ventilation. His incisions are dry and intact, and his blood pressure is now 118/62, with a heart rate of 92. What other assessment measures are necessary? We want to focus our continued assessment on his tissue perfusion, including vital signs, peripheral pulses, his level of consciousness, capillary refill, the skin itself, such as temperature, color, moisture, and urine output. Following our brief history of events leading to the shock, onset and duration of symptoms, we also want to take a careful history, including his medications, allergies, vaccinations, and recent travels. AM's mother and girlfriend arrive in the ICU. His mother tells you that he has a history of GERD, but is otherwise healthy. His clinical problems may include impaired cardiac function, impaired respiratory function, and altered blood pressure. Our care goals for this patient would include adequate tissue perfusion, the restoration of normal or baseline blood pressure, the recovery of organ function, avoiding complications from prolonged stages of hypoperfusion, and preventing healthcare-associated complications. In the case of prevention and health promotion, we want to identify patients at higher risk, such as older patients, those who are immunocompromised, those with chronic illnesses, and previous surgeries or trauma patients. When planning to prevent shock, we want to monitor the fluid balance to prevent hypovolemic shock and practice good hand hygiene to prevent the spread of infections. The acute care for this patient would include monitoring the patient's ongoing status, identifying trends to detect changes in the patient's condition, plan and implement nursing interventions and therapy, evaluate the patient's response to therapy, provide emotional support to the patient and caregiver, and collaborate with other members of interprofessional team to coordinate the care. AM stabilizes over the next 2 days and is extubated. He recognizes his family and has many questions about why he's here. What other consults would be helpful? We want to make sure we're reviewing the system's approach to continued nursing care, as we'll discuss further on the next slide. As he recovers, a careful neurologic status and examination is going to be crucial. We want to assess his orientation and the level of consciousness every 1 to 2 hours. We want to make sure he's oriented to person, place, time, and events. Also, helping to reduce the noise and light levels in the ICU to promote recovery and try to keep his circadian rhythm in balance with a day-night cycle. We also want to monitor his cardiovascular status carefully, including heart rate with continuous ECG, blood pressure. Also monitoring closely for dysrhythmias, abnormal heart sounds such as murmurs in S3 or S4. We also want to closely watch his respiratory status, including respiratory rate, depth, and rhythm. along with his breath sounds, continuous pulse oximetry, and arterial blood gases. Many patients will be intubated and on mechanical ventilation. Closely watching the renal status as well, including urine output, along with a serum creatinine. Also, closely monitoring that body temperature with skin changes for a core temperature, pallor, flushing, cyanosis, diaphoresis, or a piloerection. When monitoring his GI status, we would auscultate the bowel sounds, along with NG drainage and his stools for occult blood. We also want to make sure we're keeping up with personal hygiene, including performing bathing, nursing measures carefully, turning every 1 to 2 hours, that passive, active range of motion, and oral care. We also want to assess the patient's level of anxiety, fear, and pain, combined with interventions such as drugs, his spiritual needs, involving the other caregivers, giving simple explanations for all procedures, ensuring privacy, and making sure the call light's within reach. For ambulatory care, rehabilitation of patients requires correction of precipitating causes, the prevention or early treatment of complications, and teaching focused on disease management or prevention of recurrence. For evaluation, we want to make sure we're looking closely at evaluating the tissue perfusion with restoration of normal or baseline blood pressure, normal organ function with no complications from hypoperfusion, and a decreased fear and anxiety along with increased physiologic comfort. When assessing a patient in shock, the nurse recognizes that the hemodynamics of shock include A. Normal cardiac output in cardiogenic shock, B. An increase in central venous pressure in hypovolemic shock, C. An increase in systemic vascular resistance in all types of shock, or D. Variations in cardiac output and decreased systemic vascular resistance within septic shock. The answer is D. The variations in cardiac output and decreased systemic vascular resistance in septic shock. Septic shock has 3 major pathophysiologic effects: vasodilation, maldistribution of blood flow, and myocardial depression. Patients may be normovolemic, but because of acute vasodilation, relative hypovolemia and hypotension may occur. The ejection fraction is decreased for the first few days after the initial insult. Because of a decreased ejection fraction, the ventricles will dilate to maintain stroke volume. The ejection fraction typically improves and ventricular dilation resolves over 7 to 10 days. Persistence of a high cardiac output beyond 24 hours is an ominous finding and is often associated with increased development of hypotension and even MODS. Systemic vascular resistance, SVR, increases in cardiogenic and hypovolemic shock. Systemic vascular resistance decreases in neurogenic, anaphylactic, and septic shock. Finally, cardio output decreases in cardiogenic shock, along with central venous pressure decreases in hypovolemic shock. The nurse is caring for a critically ill patient. The nurse suspects that the patient has progressed beyond the compensatory stage of shock if what occurs? A decreased blood glucose level. B, an increased serum sodium level. C, increased serum calcium levels. Or D, increased serum potassium levels. In this case, the answer is D, increased serum potassium levels. Hyperkalemia occurs in the progressive phase of shock, when cellular death liberates intracellular potassium. Hyperkalemia will also occur in acute kidney injury and in the presence of acidosis. The nurse is caring for a patient in septic shock. Which hemodynamic change would the nurse expect? A, increased ejection fraction. B, increased mean arterial pressure. C, decreased central venous pressures. Or D, decreased systemic vascular resistance. The answer in this case is D, decreased systemic vascular resistance. Patients in septic shock will have a decreased systemic vascular resistance, decreased ejection fraction, a decreased mean arterial pressure, and a decreased central venous pressure, preload. And this is expected in hypovolemic or obstructive shock. Moving on, let's talk about SIRS and MODS. Systemic inflammatory response, or SIRS, it can result from a variety of injuries. This is a generalized inflammation of the organs remote to the initial insult. Triggers include mechanical tissue trauma, burns, crush injuries, or surgeries, and can also have abscess formation, intra-abdominal extremities, and also ischemic and necrotic tissue, such as from pancreatitis, vascular disease, or an MI. Other triggers for SIRS could be a microbial invasion, such as bacteria, viruses, and fungi, endotoxin release from gram-negative and gram-positive bacteria, the global perfusion deficits, such as post-cardiac resuscitation or shock states, and finally a regional perfusion deficit, such as a distal perfusion deficit. Not to be confused with MODS. This is a failure of two or more organ systems. In this case, homeostasis cannot be maintained without intervention and can even result from SIRS. Below we have figure 42.1 from the textbook, which shows the relationship of shock, SIRS, and MODS on the central nervous system. In this case, after the shock, it moves on to SIRS. And then finally, we end up with multiple organ dysfunction syndrome, as we have dysfunction of everywhere from the cardiovascular, lungs, or GI tract to the liver, central nervous system, renal dysfunction, or skin dysfunction. In our next case study, KR, a 28-year-old woman, is brought to the ED by her mother with confusion, fever, and flu for the past week. She's been vomiting for the past 2 days and has noted generalized edema, vital signs with a temperature of 103.5, a heart rate of 112, respirations at 24, and a blood pressure 88/54. The pathophysiology of SIRS and MODS include the consequences of that inflammatory response, such as the release of mediators, direct damage to the endothelium, hypermetabolism, increase in vascular permeability, and an activation of the coagulation cascade. Eventually, organ and metabolic dysfunction occur as a result of hypotension, decreased perfusion, the formation of microemboli, and the redistribution or shunting of blood. As far as the respiratory system, we would carefully watch for alveolar edema, any decreases in surfactant, and be very aware of that ending result of ARDS, acute respiratory distress syndrome. In the cardiovascular system, myocardial depression and massive vasodilation can result in a decreased blood pressure. Baroreceptors respond to that increased cardiac output, and also be aware of albumin and fluid moving out of the blood vessels. In the neurologic system, the mental status changes due to hypoxemia, inflammatory mediators, and impaired perfusion are often an early sign of MODS. Confusion, agitation, combative patients, a patient suddenly combative, and lethargy. Also, the renal system is very sensitive to changes in blood pressure. And as a result of hypoperfusion, the release of mediators, the activation of the renin-angiotensin-aldosterone system, and nephrotoxic drugs, especially antibiotics. In the GI system, motility is decreased, along with abdominal distension and paralytic ileus. Decreased perfusion increases the risk for ulceration and GI bleeding, and the potential for bacterial translocation. Another major danger is going to be disseminated intravascular coagulation from dysfunction of the coagulation system. Also, be very aware of electrolyte imbalances and metabolic acidosis. In study, KR is admitted to ICU with a possible diagnosis of sepsis. Her urine output is amber and only 15 milliliters in 2 hours. The chest x-ray shows bilateral infiltrates, and her white blood cell count and lactic acid are high. The prognosis for MODS is poor, and the goal is to prevent the progression of SIRS to MODS. Vigilant assessment and ongoing monitoring to detect these early signs of deterioration or organ dysfunction are critical. The care for these patients with MODS focuses on preventing and treating infection, maintaining tissue oxygenation, nutrition and metabolic support, and appropriate support of individual failing organs. AR has a urinary catheter inserted, as well as a central venous catheter. The provider talks with her mother about the possibility of mechanical ventilation. KR's mother asks why she is so sick and what can be done to help her. There's going to be a lot of interventions we would expect here, everything from antibiotics, sedation, nutrition, and obviously focusing on that respiratory system. Preventing and treating that infection, those aggressive infections are control strategies to decrease the risk for any hospital-acquired infection, using strict asepsis and aseptic practices, and assess the need for invasive lines. Once an infection is suspected, begin interventions to control the source. Aggressive surgery to remove necrotic tissue, aggressive pulmonary management, and
early mobilization wherever possible. We also want to work aggressively to maintain tissue oxygenation and decrease that oxygen demand while increasing oxygen delivery. Strategies such as sedation, mechanical ventilation, analgesia to control pain, rest, and treating fever, chills, and pain. The goal of nutrition support is to preserve organ function. The total energy expenditure is often increased 1.5 to 2 times, making proper nutrition and metabolic needs critical. We want to use enteral nutrition when we can, with parenteral nutrition as a last resort. Also, monitoring plasma transferrin and prealbumin levels to assess hepatic protein synthesis. The nurse notes that KR has developed petechiae and jaundiced skin. What does this indicate? Jaundice is going to be a key indicator if we've got a liver problem developing. Also, what are some treatments that you would anticipate being done for her? Well, that jaundice indicates that increased bilirubin level from impaired liver function. The petechiae could also indicate disseminated intravascular coagulation. A priority is going to be aggressive treatment of the infection, maintaining her oxygen levels, even with intubation and mechanical ventilation if necessary, and thoroughly assessing all body systems. When assessing and identifying failing organs, in the case of ARDS, aggressive O2 therapy and mechanical ventilation. For disseminated intravascular coagulation, we're going to be seeking out appropriate blood products. And for renal failure, we want continuous renal replacement therapy or dialysis. Also, consider the further interventions may be futile. Communicate with the caregiver about realistic goals and outcomes. And wrapping up, a patient with a history of alcohol use is admitted to the ICU with hemorrhage from esophageal varices. The admission vital signs are a blood pressure of 84 over 58, a heart rate of 105, and a respiratory rate of 32. The nurse recognizes the onset of systemic inflammatory response syndrome upon finding A. dysrhythmia, B. pulmonary edema, C. absent bowel sounds, or D. decreasing blood pressure. And that answer is B. pulmonary edema. The respiratory system is often the first symptom to show signs of dysfunction in systemic inflammatory response syndrome, or SIRS. Increases in capillary permeability facilitate the movement of fluid from the pulmonary vasculature into that pulmonary interstitial spaces. The fluid then moves to the alveoli, causing alveolar edema and pulmonary edema. Anyway, that's all we've got for this chapter. I'll see you in the next slides.